Hello everyone, my name is Dr. Carly Schrage. I am an otolaryngologist, also known as an ear, nose, and throat surgeon. I have a particular interest in sleep apnea and sleep surgery, and so I'm going to be talking to you today about effective treatment for sleep apnea. Thank you for joining me. Okay, so the outline today, I'm going to start with what is obstructive sleep apnea, who has it, what are the symptoms and health consequences, the causes, and then try to focus most of our time on the treatments because I think that's what everybody is most interested in. Sleep disordered breathing. So this is the overarching category of people who have disruption in their sleep related to some sort of breathing problem or abnormality. That encompasses snoring, also obstructive sleep apnea and central sleep apnea. And we'll go through each of these and talk about how they differ and how they overlap. So snoring can be a sign of having obstructive sleep apnea, or it can just occur on its own. It's not a dangerous condition when it occurs in isolation on its own. And when it does occur on its own, the main goal is to improve the breathing through the nose, and that can help stop snoring. There's a gentleman here showing how to use a Breathe Right strip, or one of those adhesive strips for the dorsum or the top of your nose that can help hold your nose open and improve breathing when you're sleeping and treat snoring. All right, but snoring can also be a sign of sleep apnea, and sleep apnea comes in different forms. It can be central, obstructive, or mixed, which is when central and obstructive occur together. So central, that's when your brain doesn't send the signal to your body to breathe. There's a pause in breathing, and it's not because there's some sort of obstruction happening, but it's because your brain took a pause and decided not to tell you to breathe. So throughout the night, you're taking these pauses in your breathing. This is generally a neurologic condition. It can occur because someone's had a stroke before, maybe they have Parkinson's disease, or a history of heart failure, or different things that can end up causing some sort of neurologic abnormality. This is not the typical type of sleep apnea that most people think about, but it is important to know about. Obstructive sleep apnea is the other type. That's when your body is trying to breathe and you're physically trying to take a breath, but you can't because there's some sort of collapse or obstruction in your airway that's preventing you from breathing. So you can see a picture here. There's air going in through the nose and through the mouth, but it can't get by into the trachea because either the tongue or the soft palate or other tissues in the throat are collapsing and preventing the airflow. So who has obstructive sleep apnea? From here on out, we're going to really focus on the obstructive form and the treatments and things for obstructive sleep apnea. So who has obstructive sleep apnea? It is in 30 to 60-year-olds, it's about 9 to 24% of men and 4 to 9% of women. And this is numbers in the United States. So you can see it's more common in men than it is in women, but it occurs in both sexes. It's also more common as you get older, so 2 to 3 times more common in the over 65 age group than the younger age group. And again, 2 to 3 times more common in men than women. But that, we don't want to ignore it in women because people often think of this as a problem that men have, and then we miss the women who have it, and that's important to remember that they have it in significant numbers as well. And then African Americans and Chinese people are more likely to have obstructive sleep apnea, and that has to do with just their anatomy and the shape of their anatomy. And we'll go over different anatomical abnormalities that put you at increased risk. So what are the symptoms of obstructive sleep apnea? When might you be concerned that you have this condition? Certainly snoring can be a tip-off, but also your bed partner can tell you it looks like you pause breathing when you're sleeping. You know, I look at you and it looks like there's long periods where you're not breathing anymore. Restlessness while you're sleeping, waking up gasping, being tired during the day, having headaches in the morning, and being dizzy. These can all be symptoms of obstructive sleep apnea. So why do we care about obstructive sleep apnea? Well, it has a lot of health consequences. There's a significant increased risk of death from stroke or heart attack for people who have obstructive sleep apnea. And also 2 to 7 times increased risk of getting into a car crash. And that may be because people are falling asleep at the wheel, or maybe they're just not quite as attentive when they're driving because they're tired. And so it's not just about the heart attacks and strokes, but it's about things like car crashes. It really affects lots of parts of your life. It can be a big burden on your quality of life. These risks are frequently reversed when you treat the sleep apnea, and that's why we get so passionate about making sure these patients get treated effectively. So what are the causes of sleep apnea? Weight is the biggest factor, but there are anatomic factors as well. So people think of it as a problem with people who are obese, but there are plenty of very thin people who have it as well, and plenty of obese people who don't. So weight is not the only factor, but it is significant. So if you have an increased neck circumference, as the gentleman is showing here, or an increased BMI, you're at increased risk for sleep apnea. Now, what are the anatomic issues that might put you at increased risk? One is a small jaw. So this x-ray is trying to show you that the lower jaw is smaller than normal. And when the jaw is smaller, it pushes the tongue back and it causes less room behind the tongue for air to flow, and a higher chance that a little bit of collapse during sleep will cause an obstruction. So some people are born with abnormally small jaws, or maybe still in the normal range, but a little smaller than usual, and that puts you at increased risk. Large tonsils and adenoids are also a problem, particularly in children. A lot of times we can cure obstructive sleep apnea in children by removing tonsils and adenoids. Not usually so simple in adults, but they definitely are a factor. A long, soft palate and a large tongue. So you can see when you look in someone's mouth, it can look like a lot of different things. On the left here, you can see the uvula, which is that area that hangs down in the middle, and you can see the back of the throat, no problem. On the right, you can't see any of that. And there's a range of what things look like when you look in people's throats, and that may be because the tongue size is different, or the configuration of the soft palate is different. So the people on the right are much more likely to have obstructive sleep apnea than the people on the left. Other causes are problems that cause poor neuromuscular tone while you're sleeping. So you might just have all your muscles get a little bit more floppy when you sleep and a little bit more likely to collapse. So some people are just naturally like that. They just really relax their muscles when they sleep, and they have a little bit more of that. We also see that in people with Down syndrome, muscular dystrophy, Parkinson's disease. A lot of different conditions can cause poor muscular tone while you're sleeping. So now on to treatments. The rest of the talk we're going to focus on treatments for sleep apnea. So first of all, lifestyle treatments. Weight loss. Weight loss is a really big one. For a lot of people, this can cure your sleep apnea. And even as little as 5-10 pounds can make a big difference depending on your anatomy, your configuration, and your weight. So that is a big one. Also, exercise. So even purely apart from weight loss, exercise is helpful in treating sleep apnea. So there's something about having that heavy breathing during exercise that we think strengthens some of the muscles in the throat and makes it less likely that you have sleep apnea. So don't be discouraged if you're not losing weight. Exercise is still important and helpful. Alcohol consumption. So if you drink a lot of alcohol right before you go to bed, that causes poor muscular tone, and it can increase sleep apnea. So try to avoid alcohol. Sleeping on your side can help. Some people have sleep apnea on their back, but when they turn to their side, they're in the normal range. And elevating the head of the bed. So same thing. Some people, if they lie flat, have sleep apnea, but if you put the head up a little bit, it can at least make it much improved, if not eliminate it. So these are all different lifestyle things you can do to treat the sleep apnea. Next on the list is a dental appliance. So these are appliance for people who, generally for people who don't tolerate the CPAP therapy, and we'll talk about CPAP therapy here in a minute. But these appliances work to either move your lower jaw forward, maybe move your tongue forward, or lift your palate up. So this is an example here on the right where the lower jaw is being pulled forward, and that can prevent the collapse of the tongue behind. These are generally devices that are made by a dentist, and they're fitted personally to you, and they can often be adjusted depending on how you're doing with the device. There are some reasons why you might not be able to get a dental appliance. If you don't have enough teeth, there's not enough teeth for the appliance to hold on to. Also, if you just have limited jaw motion, so when it's trying to move your jaw forward with the appliance, it's unable to do that successfully. Or if you have problems with your temporal mandibular joint, which is your jaw joint, or issues with clenching and grinding of your teeth. These might all be reasons why you would not be able to use a dental appliance. They tend to work best for mild cases. You can see some of the success rates here. I will say, take all these success rates in this talk with a grain of salt. These are all from different studies. They use different metrics for defining success, and so we can't really compare them head to head from these numbers. But this gives you an idea. It's much more likely to treat your sleep apnea successfully if you're in the mild range than the moderate or severe range. Occasionally, these devices can worsen your sleep apnea, so we should not assume just because you're wearing a device you are being successfully treated. I encourage all of my patients who get these devices to get a repeat sleep study while wearing the device to make sure that it's working and that their numbers are in a good range. Okay, so there are some problems with these devices. Sometimes they cause issue with jaw misalignment or temporal mandibular joint pain and issues, maybe teeth movement over time, causing your teeth not to fit together normally. Some people tend to drool and salivate while they're sleeping with these devices in place, and they can cause some irritation. So all of that together, fewer than 50% of people really wear their appliances consistently. And if you're not wearing it, you're not being treated. So it's really important to reevaluate if you find one of these devices is not working for you. They are sometimes not covered by insurance. They really range in cost, so that can be another factor sometimes when people are choosing what type of treatment they want for their sleep apnea. Okay, before I go on to this slide, I just want to mention we are accepting questions over the chat, so if you guys have questions, you can always submit them and we can address them at the end of the talk. Okay. So CPAP therapy, this is the big one everybody talks about. CPAP stands for continuous positive airway pressure. There's also BIPAP therapy, or bi-level positive airway pressure. And these are different devices that you wear while you're sleeping that treat obstructive sleep apnea. And you can see this gentleman here has the full face mask that goes over the nose and the mouth. And what it does is it gives a pressure of air, and we call it a pneumatic splint. So think of it like air pressure holding your throat open. So with the CPAP, it's one solid constant pressure. With the BiPAP, the pressure changes depending on whether you're breathing in or breathing out, but it's still always a pressure that's forced in. So this is something you'd wear all night long, and really is almost always successful in resolving sleep apnea if it's worn consistently and at appropriate pressures. So really important treatment, is a life changer for a lot of patients. But not everybody can wear it. The numbers really vary, but some say about 68% are adherent to their therapy at 5 years. And again, if you're not using it, you're not being treated effectively for your sleep apnea. So it's a really important therapy for a lot of patients, but not everybody can tolerate wearing it all night. So we're moving on to surgery. The surgery section is the last big section of our talk. It's what I tend to be most interested in, since I am a surgeon that deals with a lot of these issues. So we're going to step through these different types of surgery. Nasal surgery is the first one. So think of nasal surgery as improving tolerance to a CPAP mask or improving snoring. It does not tend to cure obstructive sleep apnea. Everybody wants their septum straightened and thinking that that's going to mean they don't have sleep apnea anymore, and that's generally not the case. Any changes to sleep apnea are very modest if you're just doing surgery on the nose. This is a picture here you can see of someone's septum. It's crooked off to one side, and we can straighten that and get it in the center, and that often improves the breathing through the nose. Okay, so there's a lot of tissues that are, a lot of surgeries that are geared towards removing tissue. So now I'm going to talk about tonsillectomy and uvulopalatal-pharyngoplasty, or UPPP. Okay, so this is the same, this is looking in the back of someone's throat. You can see the uvula and the tonsils. Now, removing the tonsils is pretty self-explanatory. It tends to make more room back there. And then uvulopalatal-pharyngoplasty, the earlier versions are that top right version where people just essentially removed the uvula, excuse me, and removed some of the soft palate to make room. The newer versions are a little bit different. Often we keep the uvula intact, and we tend to resuspend some of the muscles, and these newer versions work a little bit better. Also done to this area of the mouth, you can do radiofrequency ablation of the palate or palatal implants. So these are all geared towards addressing the issues with the anatomy in the back of the throat. So the older techniques tend to have about a 68% success rate. The newer techniques are much higher. Again, this depends on how you define success and how severe your sleep apnea is. But in the right cohort of patients, these surgeries can be very successful. Problem is they tend to be very painful, a very rough recovery, so really hard for patients to tolerate. And effects may not be long-lasting in some patients. Some patients find really good success initially, and then over the years that can wane a little bit. Okay, so tongue-based resection. So if we look at the picture here, the back of the tongue is often a culprit for falling back. So in the right patient, sometimes we can remove either the lingual tonsil tissue on the back of the tongue or some of the actual tongue muscle itself to address this obstruction. The success of that one really depends on the patient, and it's really hard to kind of compare it with numbers here. Okay, so upper airway stimulation device, Inspire Implant. So this is, I think, the most exciting of the treatments we're going to talk about today. This is a surgical treatment for sleep apnea that I do, and it's implanting a nerve stimulator. So this is, you can think of it kind of like a pacemaker for your tongue. So it's implanted on the right side. Everything you see in that picture is done under the skin. So nothing's on the outside except for that remote control that that gentleman is holding. The remote control is used to hover over the device and turn it on and off. And then the device has a wire that goes up to a nerve in your neck, and it stimulates the nerve, and a wire that goes down to a breathing sensor between your ribs. So what you do is you turn the device on at night, and then whenever it senses that you're breathing in, it gives a little impulse to the nerve in your neck, and that causes the tongue to move forwards and out of the way. So with each breath, the tongue is moving forward. So you can feel it, you can see it happening. It also activates some of the other airway muscles to open the airway while you're sleeping. So generally you turn it on at night, and it's set to have a delay to allow you to fall asleep before it starts to activate. And then while you're sleeping, it's activating those airway muscles with each breath, preventing the obstructions from occurring. So really new, neat, revolutionary treatment for sleep apnea. It's for moderate to severe sleep apnea. You cannot be too overweight. There is a BMI limit for most insurance plans. And you must pass an airway exam to make sure you're a good candidate for the device before implantation. There is a battery life on the device. It lasts about 11 years. And then after that, just the battery portion of the device would have to be replaced. And there are some restrictions on MRI compatibility, but it's still safe to get MRIs of your head, neck, and extremities. The advantages of it is there's no resection of tissue. You're not altering anatomy in any way. It's more portable. All you really need to bring around with you is that little remote control. So that is a little bit of a nice factor over CPAP, where you're carrying your machine and your mask everywhere. it is greater than 80% effective in the right patient population. So we're getting really good numbers compared to other sleep surgeries. You know, it's still not as effective as CPAP if you are able to use your CPAP all night, every night. But for people who cannot, it's a really nice option. And the studies show it continues to be effective 5 years later, and it's tolerated quite well. And it is covered by insurance. More and more insurance plans are writing a policy for the Inspire implant, so we are able to get it covered most of the time. Okay, so just a couple other mentions quickly here. Jaw surgery, maxillomandibular advancement. So this is generally done by an oral surgeon. Essentially, they're breaking your jaw and moving it forward, and that can be your upper jaw, your lower jaw, or both. It's a pretty rough surgery to recover from. You know, they break your jaw in multiple places, move it forward, and then put plates and screws to secure it in the new location. Generally, your mouth is wired shut. You can only have liquids for many weeks. It can change the way you look as well, because it's actually moving your bones around in your face. But that is an option for some people, and it can be really effective in the right patient. Yeah, like I said, long recovery, you're wired shut, lots of swelling, modified diet for a while, but it can be really effective. And then I just want to mention tracheostomy to be complete. You know, it appears to be a fairly drastic treatment for sleep apnea, but for some patients it is a lifesaver, and it is 100% effective at treating sleep apnea, 100% success rate. So what a tracheostomy is it's a breathing tube. So instead of breathing through your nose and mouth, you breathe through a hole in your neck, and it goes straight into your windpipe or your trachea. So you don't have to be hooked up to a ventilator or anything like that. It's just an alternate path for the air to follow, and it bypasses all the obstruction and obstructive sleep apnea. So people who have extremely severe sleep apnea can get a tracheostomy, and they'll have zero obstructions. Okay, so conclusions. Obstructive sleep apnea is a widespread problem with severe health and quality of life consequences. The traditional therapy is CPAP, which is effective if it's tolerated and used. But there's lots of other therapies that range in invasiveness, side effects, complications, effectiveness, and cost. And you should speak with your sleep doctor about what might be best for you and your friends and family. Okay, so I just want to list my offices here, Newport Beach, Irvine, and Seal Beach, and my office phone number there. And now I'm going to take a question. Okay, so the question is, how is a sleep study conducted during COVID times? So, good question. Yeah, for a long time, we were not doing traditional in-house sleep studies. So there's a couple different ways to do sleep studies. You can do one at home, or you can come into a facility and do one in the facility. And for a period of time, a lot of facilities were not doing those in-facility sleep studies. But I believe most are open now to doing those again. And so you can do one at home if you feel safer, more comfortable. Those tend to not give us as much information, but they're often still really accurate and often a good alternative. So you're sent some sort of device to wear at home. There's different ways that those can be done. And then, but most facilities are doing the in-facility sleep studies now for people who want to come in and do that. So how much time should you give yourself to adjust to a CPAP machine? Now, that's a really personal question. I think that as much time as you need to really feel like you've given it a good shot. You know, for some people, it's just a matter of finding the right mask, and it might take quite a bit of time to go and try various different masks. And you know, there's one that's just nasal pillows, and so it's kind of a couple little prongs that go under your nose. That tends to be a lot more comfortable for patients if you can tolerate it. So it might take a while to try each different mask and work with it, and work with your sleep doctor, try adjusting the pressures. Some people have to wear their mask while they're awake for a period of time, so they can kind of get used to how it feels and how it feels to breathe. You might even wear it while you're watching TV, and so you just kind of get acclimated to it. So it might take many months to do that. Other people, I think, realize pretty quickly that it's not going to work for them for one reason or another. But I would really encourage people to work with it and give it a good shot, because the surgeries are good, but they're not as good as the CPAP machine. They're not as reliable, and you have to go through a surgery, which is often associated with pain and risk of complication. How aggressive should you seek treatment beyond a PAP machine if you already have AFib? Would you recommend getting surgery in addition to using PAP, or just a PAP machine sufficient? So certainly if you have AFib, you should be especially aggressive at treating your sleep apnea. You already have one of the complications that's associated with sleep apnea, puts you at increased risk, so it's extra important for you to treat it. If you're able to wear the PAP machine successfully, then that is enough. You don't need surgery in addition. But if you're not, then yes, you should probably pursue some sort of surgical option. Now, that depends a little bit on the severity of your sleep apnea. Obviously, the more severe it is, the more important it is to treat, and the more mild it is. If it's really mild, a little less important. But if you have AFib, I would really work to see what you can do to get into the normal range. All right, I think this will be our last question for the day. Which CPAP machines are BIPAP, and what are the pros and cons? So usually, the BIPAP, usually we don't move to a BIPAP machine unless the patient's having trouble with the CPAP and they're not tolerating it well. Sometimes the BIPAP helps people adjust to it better and feel more comfortable with it. I will say also people with central sleep apnea or mixed sleep apnea sometimes do better on a BIPAP than a CPAP. So that's a reason why you might be choosing one over the other. And really, as long as the sleep apnea is being treated successfully, it doesn't matter which one you have, as long as you're comfortable, you're using it, and your numbers are good. And for people with mixed and central sleep apnea, the BIPAP may be required to improve their numbers more. All right, maybe one more. How is the level of apnea, mild, moderate, etc., determined? So that's a good question. We do it based on something called apnea-hypopnea index. So that is the number of times an hour that you stop or slow your breathing enough that your oxygen dips. So for normal is less than 5 times an hour that you would stop your breathing and your oxygen dips down. Mild sleep apnea is 5 to 15, moderate is 15 to 30, and severe is over 30. So people who are severe, more than once every 2 minutes, they're dipping their oxygen at night. And sometimes it can be quite low. So it's really hard on your body to be dealing with those low oxygen levels all night long. And it's one of the reasons why people sometimes wake up with headaches who have sleep apnea. All right, well, I think that's it for today. I thank everybody who joined today, and thank you for your questions. Again, my name is Dr. Carly Schrage, and you see my offices there and my phone number. I'm happy to see you for a consult if you're interested, and have a nice evening.